Hello?
Hello.
Hello. Now I don't see
Hello?
you. Is this
This is
Here we
me.
go.
This is
Yeah.
me, Peter.
Hello.
Yeah. Hello.
Hello.
So, okay, you're welcome here in the Houses of Parliament here in Copenhagen. So you have, what was it we've talked about? You're going to tell us a bit about your book, your new book on how to get off psychiatric drugs with an emphasis on antidepressants and questions. And you're on the big screen.
Okay.
Yeah.
Well, first, thank you. I'm very pleased and honored to be addressing you. And I want to thank Eckendorf for helping to arrange this. And Olga Huntsman, I want to thank you for being there to help out.
You're welcome.
Have I been introduced in any way?
No, not really. So you're going to introduce yourself.
All right.
Yeah.
I'd like to give you an overview of the antidepressants and their dangers. And if I could go on too long, just give me a time notice. I'm Peter Bregan. I'm a psychiatrist. I'm currently in Ithaca, New York, which is upstate New York. I went to Harvard and had my medical training at Case Western Reserve and some of my advanced psychiatric training at Harvard and at the State University in upstate New York. I've been in practice since 1968, which gives you an idea that I'm in my 70s. I've written about more than 20 books and more than 40 scientific articles over the years. I became heavily involved with issues around antidepressants in 1994 when I was asked to be the medical expert for all of about 150 lawsuits against the drug company Eli Lilly for fraud, alleged fraud in regard to Prozac causing violence and suicide. So I was the first person to look inside the company vaults, in a sense, to see what no other person has ever seen since, probably. And as a result of that, I have been involved in a variety of research, and also I've testified in court in criminal cases where antidepressants have caused violence or suicide, and I've been involved in malpractice suits against doctors who misuse the drug, and will continue to be involved in lawsuits against drug companies for failure to disclose or facts about the drugs or for improper marketing. So I think it's safe to say I have a lot of experience in what I'm about to share with you today. One of the first things that was noticed about Prozac before it was even approved by the FDA, and this was noticed inside the FDA, which is our drug monitoring agency, that the drug was causing a lot of overstimulation or agitation, very similar to amphetamines or cocaine. Patients were having trouble sleeping, they were getting agitated, they were getting anxious, some were getting suicidal. And the doctor, the psychiatrist in charge of looking at the adverse effects of the FDA wanted a warning in the label that the drug might worsen depression by making people agitated. And an agitated or upset or overstimulated depression is a very dangerous situation. People get violent, they get suicidal. So from the beginning, problems with Prozac were known, but both the FDA and the drug company refused to allow this information to be made public. I wrote about it in one of my early books talking back to Prozac. So from the beginning, it was very easy to show that this drug had a lot of dangers. It was, however, very hard to show it was helpful. Looking inside the company, I found that, in fact, they could not show that Prozac was helpful to patients unless they also gave the patients addictive tranquilizers, like alprazolam, which is Xanax in our country, or Valium, which is diazepam, that the patients were often so overstimulated that they just drop out of the studies. So the approval of Prozac was actually illegitimate. It included patients who were taking addictive drugs. It was the only way they could get it approved. To give you an idea of some of the more, how should I say, shocking facts about the approval of these kinds of drugs, I found as a medical expert that Eli Lilly knew that Prozac was causing suicide attempts at a very high rate in their controlled clinical trials, that is, in the experiments used for FDA approval. But they withheld this information from all of the agencies, the German agency, the American agency, that were approving the drugs. They had, depending on the count, between 6 to 12 times more suicide attempts on Prozac than on an older drug and on the sugar pill, placebo. And that data was unknown until it came out as a result of my looking inside the company. Another thing that Eli Lilly did, this is to just give you an idea of the unreliability of the data we're dealing with. When Eli Lilly would get a report from one of its own researchers that they thought the drug had caused a suicide or a suicide attempt, Eli Lilly would recodify it from a suicide attempt to something like no drug effect or depression, literally hiding the data. So when the FDA then went to examine the data later on, they didn't have an accurate picture. This was so bad that actually we have a memo from a German member of Eli Lilly to the company's American and German leaders, saying that he was ashamed of doing this and that he wondered how he could explain it to a judge or to his own family. GlaxoSmithKline, in regard to the manufacture of Paxil or paroxetine, also hid their suicide information under other codes, such as emotional lability, which is a very minor adverse effect compared to suicidality. They also fudged on their numbers, and after I blew the whistle on that, because I was also an expert in product liability against Glaxo and Paxil, the FDA told them to stop doing it. Now, we know that these drugs cause suicide. There's no doubt about it. The FDA now has a label that we have to be concerned about children, youth, and young adults up to age 24. But there are multiple studies also showing that older adults are at risk. Right now in the United States, we have a terrible problem because we're giving these drugs to our soldiers, and as a result of that, there's been a huge increase in suicide among our soldiers. There are other factors too. There's a lot of stress on our soldiers. Their deployments into active duty are much too long and much too frequent. But one of the factors that you could plot right alongside the increasing suicide rate and suicide attempt rate is the increased use of psychiatric drugs in our military. That's a real tragedy. We also have a lot of data on violence in regard to the antidepressants and some other psychiatric drugs. I'm focusing today at request on the antidepressants. Recently in Canada, I was a medical expert in the case of a 16-year-old boy who was put on Prozac. In Canada, there were warnings about not giving Prozac to 16-year-olds, and there are warnings in Canada that this can lead to harm to self and others, not just self, but self and others. And in this case, a 16-year-old boy had a very bad reaction to Prozac. It was very much the stimulation syndrome that I was just describing to you, which is also called activation or stimulation. He was on Prozac. He got more and more agitated. His mother said to the psychiatrist that he's getting worse. He's already had a suicide attempt for the first time since starting the drug. So as often happens in North America, where I'm familiar, that is US and Canada, the psychiatrist responded to this by raising the dose of Prozac because he didn't want to believe it was the drug. And shortly after, this young man plunged a knife into the chest of another 16-year-old, a dear friend, and killed him with very, very little provocation, just some irritability. The judge in this case in Manitoba actually confirmed, if you're hearing my testimony and the testimony of a local but important psychiatrist, confirmed that he believed that I was correct, that the data was on my side, and this boy would not have committed violence without the drug, Prozac, and gave him a very light sentence, actually just enough time to arrange over a few months his discharge. We have a study now by Moore, M-O-O-R-E, and others, of all reports to the FDA, on violence. And it really confirms that these drugs cause violence. For example, the drug mostly associated with violent reports, by far and away, is not even a psychiatric drug, which tells you it's not due to the patients the drug is given to. The drug most associated with violence is a smoking aid that we call Chantix or renoxicline. It's a drug, to help you get off cigarettes, so it's hardly being given to potentially violent people. And it has the highest correlation. But after that, the antidepressants, in particularly what we call the SSRIs, like Prozac and Paxil and Luvox, there's a whole variety of them. Celexa, give you the trade names now. Citalopram and fluvoxamine and so on. And then also the benzodiazepines and the stimulants. Now, the problems go far beyond what I'm talking about here with these specific cases of suicide and violence, much broader problems, which I want to get into briefly. First of all, regarding pregnancy, when the pregnant woman takes these drugs, they pass through the placenta. They cause birth defects, they several times increases in some really horrible defects, microcephaly, which is a small head, the brain doesn't develop, heart defects in children. At birth, if you've been taking antidepressants, your child will go into withdrawal. They'll be born with a toxic syndrome and then go into withdrawal. Nursing mothers will be giving psychiatric drugs directly to their infants, and their infants can go into withdrawal. And in addition, there's evidence that when women take antidepressants during pregnancy, they have a higher risk of autism. I suspect this is because the drugs flatten the emotional responsiveness. They not only cause overstimulation, but long-term, the characteristic effect is apathy and indifference and lack of interest. And if you have a mother who's got apathy and indifference and lack of interest, I think it's an increased risk of autism. The medication for all the antidepressants causes very serious withdrawal reactions. I'm not going to spend a lot of time reading my book, but my book is called Psychiatric Drug Withdrawal Guide for Prescribers, Therapists, Patients, and Their Families. And the reason I called it a guide, subtitled it a guide for prescribers, therapists, patients, and their families, is that withdrawal from the drug causes such emotional disturbance that you need a team wrapped around the person who is withdrawing from the drugs. The drugs can cause violence, suicide, ironically mania, unexpectedly mania. They cause severe depression and depression during withdrawal. And it can be very difficult working as an outpatient doctor outside the hospital. We find that we can't get all patients off these drugs. People who have been on them for many years sometimes go through such suffering in the attempt to come off that they end up staying on small amounts. I want to comment on two concepts and then finish up with the broadest implications with these drugs. And these concepts are in my books, my scientific articles. They're in psychiatric drug withdrawal. One is medication spellbinding. When individuals are taking any psychoactive substance, whether it is a legal substance like marijuana or alcohol, or whether it's a psychiatric substance that's psychoactive, that is, that affects the mind and brain, they are rarely able to fully assess the adverse effects on their mind and on their lives. And you're familiar with this in terms of the person who's drinking much too much. That person is likely to tell you they can't live without alcohol, not that alcohol is ruining their lives. And this is typical of all sorts of psychiatric drugs. The medication spellbinding is my lay term. The scientific term for this concept is intoxication agnosia, not knowing you're intoxicated. People on these drugs, and this will be true for many listening to me, may not realize that their quality of life has gone down over the years. But if they sit down with a loved one or a friend and they talk about what games they used to enjoy, whether they like to go fishing, whether they like to play cards, whether they look forward to summer so that they can garden, whether they like to play with their dogs, whether they like to make love, whether they enjoy work, you may find that there has been a growing apathy or indifference without realizing it. Did I lose my...
Yeah, you've just, your video's gone out, but we can still hear you.
It doesn't
Oh, there you are.
It doesn't matter. It doesn't matter.
That's nice.
I apologize, that was my
You're back.
paper so
You're back.
lightly on the
Yeah.
keyboard.
Yeah.
You're back.
I hope I wasn't out too long.
No, it's just your picture. No, so,
Okay.
yeah.
So medication spellbinding really deceives folks, and for that reason, during withdrawal, it can be very dangerous either to abruptly withdraw or to withdraw without support. Friends who know that you're withdrawing, family, a clinician who's supervising you, because you may be the last to realize that your violence is driven not by being irritated with your children, but by being on the psychiatric drug. The general decline in quality of life is due to what I call chronic brain impairment, or CBI, which is just that the brain literally is not functioning as well as it used to. Journalist Robert Whitaker, in his book Anatomy of an Epidemic, has shown in the U.S. that this is swelling our disability rolls. Psychiatric drugs are swelling the disability rolls of children. Rarely did we have children on disability rolls in the past. Now we have lots. So finally, and then I'll be happy to talk with you all, we have to look at the broader loss of quality of life and work in our cultures from these drugs. Whereas I'm describing, these profound states of overstimulation leading to mania, potentially to violence and suicide, and profound apathy where a person withdraws. Those are the extremes. Millions of people around the world are having lesser effects of emotional instability, lack of engagement, lack of caring. Many marriages, I believe, are lost because these drugs not only suppress sexuality, it causes a huge amount of sexual dysfunction. Probably in more than half of people, maybe 80% of folks develop sexual disorders. But it's not just a physical disorder, it's a love disorder because the person lacks the feeling they used to have for their partner. So we're looking at a problem of epidemic proportions in subtle ways. Broken marriages, lack of engagement with children, lack of proper caring, enjoyment of life and work, that is impossible to quantify, but which I believe is widespread. Thank you for the opportunity to talk to you at such length. I very much appreciate it.
Well, thank you. Jeg tænker, I kan komme, altså jer, der vil have nogle spørgsmål, I vil kunne komme rundt til.
Hvis der er spørgsmål til brikken, så kom herop og stil dem.
Ja, så I kan se.
Ja.
Ja.
Bye.
Okay. So.
Hi.
No, you do, he can hear you if you don't.
Ah, okay.
This one's not on. Yeah,
Okay.
you just, yeah.
I'm Mimi.
Yeah.
You mentioned that these antidepressants, they can cause violent behavior. And does there exist in America like a statistic showing how many of the people who first got assigned happiness pills, antidepressants, who thereafter got given
Sig det på dansk, så skal jeg oversætte det.
antipsychotic medicine?
Oh, yeah.
Does there exist such a statistic showing this?
That they moved on, that they were started on antidepressants and moved on to antipsychotics.
Who after they got antidepressants were given antipsychotic medicine? Because we don't have that in Denmark.
Well,
right?
we have different kinds of statistics that would confirm that. For example, we know that a very significant percentage of people, up to 10%, are going to have some sort of overstimulation of a high degree from these drugs, and those folks often end up on antipsychotic drugs. We know that up to a third of psychiatric admissions to our hospitals are people who have been made psychotic by antidepressant drugs. So we have to look in different directions to see that a large percentage of people will end up in that manner. But by the way, one thing I forgot to mention is that a number of our school shootings have been associated with antidepressants. I was a medical expert in Columbine shootings, and Eric Harris was one of the two shooters. He had a blood level of fluvoxamine, or Luvox, that was ironically called a therapeutic level on autopsy by the coroner. So we have some correlations there. But to answer your questions, we don't have a statistic specifically, but we have a lot of data indicating that it's a common progression from antidepressants to antipsychotic drugs.
Yeah. Thank you very much.
You're welcome.
Bente. Ja. Okay, Erik.
Ja.
Og så Bente.
Ja.
Jeg vil også gerne høre på det.
Ja.
Hvorfor er der nogen?
Sorry, why didn't it?
Nej, bare snakke om det her.
Hello.
Hello.
So, short question. In Denmark, it seems to be that there's around 450,000 people on antidepressants, but even according to psychiatrists, it's only 1 to 2%, which is maximum 100,000 people who should have it. So there's a lot of people who should not have it who are getting it. And it seems that normal physicians, they are not really informed about what happens when you take these kind of drugs. And do you have a kind of a view on how come that the normal physicians, they are not actually informing themselves about these things? Because there must be a lot of patients coming to the clinics who ask for these things.
Well, it's a huge question, and I'm most familiar, of course, with the United States. I don't believe you do, but we have advertising on our television shows for these drugs. You don't have that, do you?
No, it's only America and New Zealand that's allowed to advertising. Yeah.
I think there's a lot of reasons that go into this. Most physicians get their information directly or indirectly from the pharmaceutical industry. They either get it directly in terms of salespersons coming to their offices, or salespersons giving local talks to them. They come from doctors who are bought by the pharmaceutical industry to go out and talk with their local colleagues, doctors who are bought to go and talk to psychiatric association meetings and medical association meetings. We know that the great majority of positive articles written in the scientific literature are actually not even written by the researchers whose names are on the papers. They're written by, it's called ghostwriting. I'm stumbling over the word ghostwriting. It should be something much more horrible than ghostwriting. Devil writing. But it's, so the information even in the scientific articles are coming through the drug companies. We have to get credits in our country that you take regular studies to show you kept up with your work. Is that the same in Denmark?
Yeah.
They're called medical education credits.
Oh, I don't know. Do you know? No.
Well, in our country, those are also from the drug companies mostly. So the vast majority of information flows through into the medical arena. And since the U.S. is a leader in writing and publishing and speaking, I'm sure that just blankets over Europe and over other countries like Denmark. So really, the average doctor doesn't know much more than the drug companies want him to know. There's another factor, which is that the patients, once they're on the drugs, can't get off of them, so the numbers keep building. But the patients don't know this. The patient and even the doctor thinks, oh, I stopped the drug for 3 days or 4 days, and I'm going crazy. I feel horrible. I need the drug. That's like an alcoholic going into the DTs and thinking they need alcohol. But the patient doesn't know this, and the doctor doesn't know this. So the drugs have that effect. And they also do the spellbinding that I talked to you about. So that the person doesn't realize that they are under the bad effects. So I think there's a lot of things, but at the heart of it is the pharmaceutical industry's control over information.
Thank you. Thank you.
Yeah.
We have a new question.
Yeah. Yeah.
We have a new question.
Yeah. Yeah.
Hello, Peter Bregan.
Hello.
I have a question. You talk about the lack of joy and the care of other people when you have been on the drugs. And also there's something about change of personality. I would like to know if there's any scientific evidence how long this will last for a person. How many years will a person feel in a way change?
When they've stopped, you mean?
Yeah, when they're stopped from the medication. If they have been on many years.
It's a very good question. Actually, all the questions are very good. But that's a particularly good one, and we don't have the answer because that level of research has to be funded. And who funds research? The U.S. government and the pharmaceutical industry. They're just not going to look at that. In my experience, all people tend to improve after they come off the drugs. It's quite remarkable that people who think the drugs have been helping, but say they're worried about sexual dysfunction, will have an overall improvement when they come off the drugs. But I don't have any statistics to say how many people fully recover or don't, just that it tends to always be good if you can get off the drugs. So there's something to be looked for or forward to. I also want to comment something else, which is perhaps unscientific, but I believe that human beings have huge spiritual resources beyond their brain. And I have worked with people whose brains have clearly been injured by psychiatric drugs and also by shock treatment, who by marshaling their spiritual strength have managed to live even better lives than before the injury. I see this in my practice all the time, so I really want to emphasize that don't be discouraged if you've been harmed by psychiatric drugs or shock treatment. I mean, of course you're going to go through some sense of bereavement or loss, but it is actually possible when you really get in touch with who you are as a human being to live an even better life than ever. I see this common.
Oh, thank you. Så er det dig.
Fordi jeg er med lidt bare stille for mig.
This is from Elizabeth. Ja?
Om alle de her forandringer skyldes de forandringer inde i hjernen, og at hvor lang tid det går, det er hvor lang tid i hjernen om at komme sig.
Altså, hvad tænker du på?
Når man stopper med pillerne,
ja,
så går der utrolig lang tid. Er det skyldes det de ændringer, der er sket i hjernen, og hvor lang tid er hjernen den er om at komme sig?
Elizabeth is asking a question about when you stop the medication, it takes so incredibly long time to get over it. You know, is that because the drugs are present in the brain, or is it the brain changes that's makes it take such a long time to sort of get rebalanced?
Well, when I give you the answer, you're going to know more than most of the physicians that you talk with. Physicians often say, well, the drug is out of your system. I mean, the half-life of these drugs is often less than a day. Prozac is longer than that. But, in fact, it's not about how long the drug is in the system. The drugs within days or weeks are going to be very little in the body. No, the brain is changed. The brain is injured. See, the brain, and thank you for that question. The brain doesn't like psychiatric drugs. It doesn't like marijuana. It doesn't like alcohol. It doesn't like cigarettes. The brain fights back and compensates. And we know the mechanisms for that, which I won't get into here, but they're in a number of my books and articles. So you have two injuries that occur when you take a psychiatric drug for a period of time. One injury is the direct effect. We now know that in fact there is harm to the brain from the longer term, and by that I mean months or years, use of drugs. There are studies showing that areas of the brain will have the loss of cells, that they will have loss of tissue. I mean, this is a serious and tragic phenomena for some patients. But always the biochemistry is being changed by the drug. Then the brain is fighting back, so you get the compensations that the brain is producing. So when you stop the drug, you have your overcompensated brain that takes time to heal. So maybe the brain is fighting against the effects of Prozac and fighting, and you stop the drug, and now the brain's still fighting for weeks or months as it heals. So you get both effects that are long-term and that can cause either lasting changes or very long-lasting changes.
And can I ask another one on you were asking a bit earlier, Elizabeth, that she says she's been damaged by the serotonin syndrome, and she doesn't really know how many people survive that. Is that very common that you can actually survive it? Because it doesn't seem to be so, at least here.
Well, first, serotonin syndrome is an remember I've been mentioning stimulation or activation. It's an overstimulation syndrome in which, in fact, often the reflexes of the body will get hyperactive. I had a patient come to me after months and months of psychiatric treatment, getting sicker and sicker, referred to me by a non-medical therapist. The psychiatrist didn't notice that she was jumping and jittery, and I tapped her knee lightly, to do a little reflex, and her entire body began to convulse. She was in what we don't think happens, but does, a chronic serotonin syndrome. And it also causes delirium, real disruptions of mental life. If the drug is stopped, very few people will die from serotonin syndrome if the doctor spots it and stops the drug. It is not known to be very lethal. Usually it's so obvious that the doctor stops the drug. However, it certainly isn't good for the brain, and it certainly can produce lasting effects. Now, unfortunately, doctors continue, in my country at least, to think that the best thing to do is increase whatever medication the patient is on. We have a lawsuit in our country. You can find her on the website, Matthew Downing.
Matthew, M-A-T-H-Y, Downing. And her 12-year-old, she was just at our conference, her 12-year-old daughter committed suicide. When she went in the hospital, she had a serotonin syndrome, and it was even noted in the emergency room that that's probably what it was. But since she was on a drug, sertraline, for so long, the doctor continued it in the hospital. It is so reflexive now. And I think this is around the world. The doctors will increase the drugs. And she was just so made disturbed by the drug that this little child hung herself after being discharged, and had a big level of this drug in her system, even though the doctors, of course, should have known better. There's something going on with the use of these drugs. It's like an abuse that people don't want to face, or they repeat the abuse. You know, if a man is abusing his wife and you say to him, I see you're abusing your wife, the risk is to go home and abuse her more. See what you did to me? You made me ashamed. To some extent, this seems to be happening in medicine now, and psychiatry. I hate to say this, but it's as if my colleagues, I'm a psychiatrist, my colleagues give these drugs, injure people, and then persist in giving them, as if to say, I reject this idea that what I'm doing is bad or wrong. yes, I agree.
Thank you. Come on here.
Yeah.
We are ready for another question.
Somebody else come. Yeah.
Hello, Peter. My name is Robert. I'd like to ask you one question about how do you separate what is coming about side effects from the medicine, and when you stop underpressing the experience and the suffering in the person with the medication, how do you separate what is what? You understand my question?
I do. Good one. Now, I gather that these questions are not being asked by physicians, because my colleagues do not ask these pointed, informed questions. They are avoiding them. And all of these questions are so on target. Generally speaking, that if you start to have a reaction between 1 and 3 or 4 days after stopping a psychiatric drug, the odds are overwhelming that it's a withdrawal reaction. And you can always, or almost always tell, because if you return to your previous dose, let's say you were on 20 milligrams of Prozac, you go down to 10 milligrams and you want to die within a couple of days. With Prozac, it could be up to a week, 10 days later, because it's got a long withdrawal. But let's suppose that happens to you. You've gone from 20 to 10. If you reinstitute the 20 and it goes away in 1 hour, which often happens, it's a withdrawal reaction. It's the same thing. Think about alcohol. If a person stops drinking and feels like they're just going crazy, they may think it's their own craziness they were covering up with their drinking, but in fact, if they then take a drink and they feel a lot better, you know that it's the alcohol abuse and that taking the drug right away works. And people go through this regularly with cigarettes. You know, they'll stop for 15 minutes and they get the agitation, the anxiety, the irritability, and the first puff or two, because it goes right into the lungs and the bloodstream will end it. So what I tell patients is, if you coming off a psychiatric drug, and within hours or usually a day or two afterward, anything strange begins to happen inside your body, mentally or physically, assume it's a withdrawal reaction, and you can always, or at least almost always, stop it by going back to whatever the dose was before this happened. Is that answering your question clearly?
Yeah, but I also think about the behavior as a side effects that is a lot of people say it's the medicine causing a lot of things, but I also think that there is something that have been underpressed that will come up again when you stop taking the medication. So I also ask because of, can you also talk about the behavior is a side effect of the drugs using? Changing your behavior.
Well, when you change the mental life of a person, you change their behavior. These drugs also have another thing I haven't mentioned. They cause akathisia, A-K-A-T-H-I-S-I-A, which causes an actual direct behavioral change of inability to sit still, that you want to jump around, you want to do something to stop that inner pain. And that is so well known, it's actually described in our official American Psychiatric Diagnostic Manual, called for short the DSM, akathisia. But I'm not sure I'm getting exactly your question. People do, of course, have emotional problems. Often they've taken the drug because they have emotional problems. But quite often by the time, I mean, if you've been on for months or years, by the time you start coming off the drug, your emotional problems are quite of less importance than what the drug has done to you and the effects you're going to get coming off the drug. Coming off the antipsychotic drugs, for example, the newer ones that are called the atypicals, people get worse psychosis than they ever had. And that's a withdrawal psychosis that people get, called tardive psychosis. Am I answering your question?
Yeah, but I think about, you talk about suicide, you talk about different behaviors. I think also that could be behind and what you are starting taking the drugs against.
Okay, I think what you're talking about is that you're depressed to start off with and are suicidal, and you're thinking that the medication is putting a lid on it, and then if you take that, remove the medication, the suicidal aspect or the whatever it was that you had before is coming up. Is that right?
And that's not about the medication.
And that's got nothing to do with, yeah, so
well, let me look specifically at the issue of suicide. Most people, acute, dangerous suicidality is very short-lived. People can be chronically depressed and chronically feel like they'd like to die, but the state in which a person is at risk of killing themselves is usually fairly short-lived. It doesn't go on for months and years, usually. There's rare exceptions. And in my experience, by the time you come off the drug, you don't, it's not the acute suicidality that occurs is actually caused by the disruption of the neurotransmitters during that process. But certainly people come off drugs, it's good for them to be in therapy, and I describe in a great deal, what you want to do to help people coming off the drug. But interestingly enough, you can't do what we call insight therapy or very psychological therapy because the person's brain is not functioning well, and you try to talk to them about something that happened bad to them in the past, trauma or family conflict, they're not able to handle it until they've recovered from the drug. So coming off the drug, you want supportive love, care, help and monitoring rather than any kind of intense therapy.
Like detoxing before, first. Yes. Thanks, and thanks for being with us.
Yes, yes.
Hello, Peter. I'm becoming a general practitioner, so this will be a physician's question.
Do you think it'll be as sharp as the other ones?
I'll try. It's instead of taking medicine. I mean, I've heard a little about your talking about emphatic listening. Can you tell short what approach do we need to have as physicians and also as other therapeutes to people coming to us with depressive symptoms?
That is a very good question. I apologize and thank you. First, I just had another thought about the last question, which is built into that question was the idea or assumption that drugs help prevent suicide. And they do not. No. We have no drug approved for that. We have no drug that does that, but we know that the drugs can worsen suicide. So I don't think you're losing anything by not giving a drug for suicide. Wow, now the other question is huge. We know, and have known for probably 200 years, that troubled and disturbed human beings need the care of other human beings. Even the most serious disturbances, like somebody who has voices that are tormenting them, or ideas that are irrational that are tormenting them, that person has lost human contact. That person no longer trusts other human beings. Often that person feels humiliated and shut out by other human beings. So what is always needed, including in the most severe distress, is another human being who can say, I want to give you another chance to relate to a person. I know you've been hurt, I know you feel hurt, I know you're scared to death, I know that things aren't going well for you, but I'm going to give you a chance to just be with me and see if we can talk about things. With the most disturbed people, you see changes in minutes once they get a sense that you are there as a caring human being. In my practice, a person who comes in looking up in the corner of the room because they are hearing hallucinations of people nagging them, criticizing them, giving them orders, will, after they begin to trust me, be no longer looking up in the corner of the room, and I'll be able to say, look, once you're being with me, once you're talking with me, once you feel a little safer, the voices go away. Now the voices might then start shouting, don't believe them, but we've made some progress. We've established that there are two conditions we can be in as persons. We can be in trusting, loving, caring relationships, or we can be crazy. And I do think that to a great extent, that's the truth of life. It may seem very large, but I think it's the truth of life. So that all good helping, and I don't care if you're a lawyer or you're a fireman dealing with an injured person, like our firemen were doing at the awful bombing at the Boston Marathon. If you come in with a caring, engaging attitude, people feel safer. Even when they're bleeding, they feel safer and they calm down. So the whole starting point for helping people when they're having terrible distress and emergencies is for you as the physician or the therapist or the friend, you don't want to have an emergency. You don't want to think, oh my God, the person's suicidal, I have to lock them up. Oh my God, the person's psychotic, I have to drug them. You want to think human beings can help each other and settle down with that other person in a caring manner. Now, we have studies that show this works. Now a well-known study out of Lapland and Finland, where when a person has their first psych, by the way, you can look it up as open dialogue, Google open dialogue, and find it. When you go when you have a person with a first psychotic break, a 17-year-old who's just really being bizarre and frightened and scared, if you go into the home with a couple of helpful people, not necessarily a psychiatrist, might be a psychiatrist, social worker, psychologist, and you involve the family so that they become more caring, so that they wrap around the suffering individual, so they look at the whole family in a way that says we have to be communicating better. They actually have practically done away with the diagnosis of schizophrenia in Lapland because the people get better so quickly. They've lessened disability even. They've improved the employment rates. So on every level, and we know that suicide, we know that the single most important factor is a relationship that matters. People commit suicide when they feel bereft and left. They commit suicide when they feel belittled and humiliated. They commit suicide when there's no one who they think is going to care, or they even want to get even with the people. So if as a friend or a therapist or a physician, you can establish within the first time you meet that you actually care about this person. In my practice, I do everything in my power to let the other person know this is way beyond professionalism. They matter as a human being. If they're distressed, even if they're not, they get my cell phone, they get my home phone, they get my office phone, they get my email. They know I'm there. And this just makes a huge difference to human beings. We need to get away from pills. You know? We got to get away from the pills and start thinking of people, because human distress is about human beings in our relationships. It is a key to life. I can answer more details.
I have a... Oh, no, sorry. Yes, somebody else. Sorry. Yes.
So here's an entirely different question. What will it take for the politician to start believing you rather than the pharmaceutical lobbyists?
Yeah.
This hearing and the wonderful people who have brought me here is a beginning in Denmark. I think that it isn't going to come from the people in power. No. Right now, the psychiatry, and to some extent medicine in general, is locked into the pharmaceutical industry. In my country, everything is drugs. Doctors know nothing about holistic medicine. They know very little about empathic relating. The demands of the health care, and increasingly so now that we have a more universal health care coming in, the demands are for efficiency, and people think pills are efficient, although they cause so much damage, they end up costing more. And that's one of the things that Denmark needs to look at. The medications, including for many medical illnesses, are causing far more harm than good. But it's going to have to come from the folks. It's going to have to be that people start saying, we're not going for these services. I don't think that the medical profession in psychiatry will stop without realizing they're losing their patients and they have to reform. So I think there's a key in that direction. And as for the political issues, you know, to some extent they follow the people. But what the people think, but in my country, they're also heavily influenced by the pharmaceutical lobby. No easy interests, no easy solutions. I keep hoping that in my lifetime it will be like the Berlin Wall. All of a sudden, things will start coming apart and people will see the truth.
I just had one question. I was wondering if I was with Robert Whittaker here just the other day, and he was talking about what I thought was very disturbing new evidence coming with children, teenagers and children on antidepressants, that it appears to give a long-term inability to feel happiness, or, you know, that one. and that the sexual problems don't seem to resolve. Not for everyone. I don't know if you've heard about that one.
Yeah, of course. Yeah, well, it's basically what I've been saying. That these drugs ruin the quality of life. So these youngsters are growing up without that sense of enjoyment, involvement, engagement. And yes, I didn't mention this, but there's increasing and strong evidence that for a good number, the word good is not good,
no.
For a large number of people, these sexual issues are not necessarily going away.
No.
But I do want to again come back and emphasize that I have seen really damaged people find better lives than ever, because before they were on the drugs, they were depressed, they were anxious, they were psychotic, and now they realize that they must take charge of their lives. They realize they can't rely on drugs or shock treatment or authorities. They realize that the starting point of a good life is to take charge of your life, to be determined to be responsible for it, and then to care about other people, to care about people who've been injured in the same way they have been, to care about young children. By the way, I'm in a hotel room right now. I'm in Tampa, and I came down to see my grandson and then my new grandson, and talking about relationships. For the first time in my life yesterday, I sat with two grandchildren in my lap.
Fantastic. So, is there anybody else wanting? I kan også spørge på dansk. Jeg vil gerne oversætte, hvis det er. Okay, there's one from the gentleman who was just before, and I think that would probably be the last question, I think. Yeah. So.
Hello again, Peter. I have another perspective. Hi again. I have another perspective.
You asked me a very complicated question.
I'm good at that. I've been searching in this, researching in this for many years in myself. I have another point of view how to look at what happens inside when we suffer. In this life, I have seriously tried one time to make suicide of myself,
commit suicide.
Commit suicide. After that, I have experience about past life. Now I have been experienced more than 50 past life. One of them was about a suicide where I committed in the life before this life. And after that, I have been through this experience, all my thoughts, and I have heavily been pressed by thoughts about taking my life. But after that, it all disappeared.
So reincarnation. Yeah.
What are your perspective about that?
Well, I'm so glad you asked that question, because it gives me a thought for maybe the best way for me to conclude. And I want to make 2 points. First, the older I get, the more I believe there's more going on in this world than we know. Far more. That there are meanings and complexities that are beyond our ordinary human understanding, and that we need to stand in awe of each other, of human life, of a higher power, of meaning. So I remain open because I know nothing, but I yearn to know everything, and I do believe that there is something much greater going on than ourselves. And I think each person has to come to that in their own way, because there aren't any simple or pat answers. But I do believe that a deep spiritual commitment, such as you're describing, is extraordinarily important in life. And then I want to conclude with a thought about suicide again. When a person comes to me and says that they want to kill themselves, I actually say, well, you know, that's in many ways extraordinarily positive. because the degree to which you hate your life and want to die reflects some concept you have that life should be magnificent, it should be better, it should be happier, it should be more creative, and you've given up on your vision of greatness and marvelousness and creativity and love, and are saying, I'd rather be out of this life than not have it. So what I say to the patients is, this is so much better than you coming in and saying you just don't care about anything. Let's take that hate you have for yourself and for life and say, that's your spiritual energy. As much as you want to kill yourself and as much as you hate life, that's the power you have to turn completely around and to become a loving and marvelously happy and creative human being. And I deeply believe this. This is not some flowery commentary. It's a truth in all of our lives, I believe.
Thank you. Thank you very much. Well, thank you very much, Peter Bregan, and thank you for sharing your time, getting up early to talk with us today.
So early,
Yeah.
and I thank you so much for handling the equipment and for doing such a good job with it, and I thank all of you, and again, Ilse, very, very much for having me.
Yeah. Thank you.
Bye-bye.
Bye. Thank you.